today. Rob Zek graduated from the University of Minnesota Medical School in 2005. He completed a residency in psychiatry at Walter Reed Army Medical Center in 2009. He was stationed at Fort Stewart, Georgia, then deployed to Iraq in 2009-2010. He transferred from Wynn Army Community Hospital to 3rd Infantry Division in 2010 to become the division psychiatrist. He deployed to Afghanistan from 2012 to 2013. Rob joined the Army Reserve in 2014 and was mobilized to active duty 3 times to work in Army hospitals in Alaska, Missouri, and Washington State. Rob retired from the Army Reserve in 2023 as a Lieutenant Colonel. And without further ado, I give you Rob Zek.
Hey, thank you, Steve. I'm going to use the, It's been a long time since I used the lavalier. It sounds like it's working okay.
Yeah, little echo.
I'm a booming. Maybe I'll move it down a little bit. Is it better down here?
It is.
I got a military voice, so I could probably do this without the microphone. I mean, you had to do it. So yes, I am Rob Zek. I am a psychiatrist. I guess I'll start out by saying a lot of people forget what is the difference between a psychiatrist and a psychologist. And we may as well talk about that. A psychiatrist is a medical doctor. We go through medical school like any surgeon or OBGYN or pathologist, radiologist, but we get 4 years of training after medical school in mental health stuff, psychology.
And you can prescribe drugs.
MD, we prescribe drugs. Why is that? Because you have to know if that drug is going to affect side effects, other organ systems in the body. So if you're giving something for mental health, you need to know what it's going to do elsewhere in the body. Psychologists, they're not MDs, they're PhDs, or they have another degree called PsyD, Doctor of Psychology. They will do much more talk therapy, assessments, a lot more research and stuff about that. So you need both to help people out. So anyway, so psychiatry versus psychology. I want to start out by saying I have recently retired from the Army, and I've had a lot of experience treating, mental health issues in soldiers and their family members. Having said that, I want to say that all the stuff I'm about to tell you is my opinion only. I am not some kind of official representative of the Army or any organization. I am just saying my own opinion about these things, so that's kind of an important disclaimer. I have an informed opinion, and it's informed by my years in medical school and residency and treating soldiers and stuff like that. But it is just my opinion. So having said that, let's get started here. This is going to be very much a broad overview of mental health problems and in the context of being in the military. This is way too broad of a subject. Steve has told me for the 30 plus years you guys have been running this lecture series that there hasn't ever been any kind of mental health presentation. So I'll be happy to do that. So I'm going to start out today with a very broad overview. This is like if you go to college as a freshman and you get a 100 level course, very elementary overview. There are many topics here. I could go on for some hours. In fact, I will come back and go into more detail about various aspects of what I'm going to tell you today. But today will just be an overview. So, having said that, let's go ahead and, thank you. Let's go ahead and get started. We're going to start with some review, and it's actually very important review when we talk about the military. And I'm going to spend a good at least 5 minutes talking about this before we delve into mental health stuff. This is a good way to think about all the different types of things there are in the military. There's combat units, and we all know about that because we see it on TV shows and movies. But then there's all these other kind of units. In fact, those other kind of units are way more of what constitutes the military than just the combat units. The combat units, okay, we got it. I've got written up there the current doctrinal, well, current as of about 5 years ago. Maneuver, fires, effects. That's referring to maneuver as like infantry units, cavalry units, which are reconnaissance units, armored units, which are tanks and stuff like that. Artillery units are the things that are called fires there. Missile units. Effects is things like, I think it's stuff like special operations and stuff like that. But those are the ground and air people that do the actual fighting. Then you got the other categories. There's this combat support category. This is referring to stuff that's alongside of all the fighting guys, but they're not themselves supposed to necessarily be fighters. So for instance, combat engineers, their job is to build bridges, lay minefields, defuse mines, and make bridges, destroy bridges, whatever. That's what they're supposed to do. But they're often, because they're on the front lines, called to be fighting also. So they would be classified as a combat support type unit. Other things like that would be MPs, military police, Navy Shore Patrol, security patrol, security forces in the Air Force. These guys are often where there's fighting. They're directing traffic or something near a battlefield and they come under fire and they got to be in combat. But that's a support, combat support. This last category you see here is the combat service support. Now that's all of that other stuff in the military, the people that do transport supplies, logistics, all of the medical personnel. This is all the administrative stuff, all the behind the scenes. There's way more of those personnel in the military than there is combat arms and stuff. Any one of these things can have mental health problems in the military. PTSD, the biggest one that most people are aware of. Any of these people can have that. Obviously, the combat arms people are probably more exposed to traumas than the other people. Anybody can get this stuff. Now, before we move on to the next slide, let's review some nomenclature about military units and sizes of units. We throw these words around a lot, and I think sometimes people may not quite know what this is if you haven't directly been in the military. So let's start out with this size of unit that's called a company. You guys have heard of a company. The best way to learn this stuff is to start with the most generic force, which is the infantry. Learn the different structures of the infantry, going higher than a company and then going lower than a company. What is the names of all those structures? How those structures interact with each other in a chain of command. And then, after you learn the infantry, you can start learning these other units that have slightly different nomenclatures, like artillery units, or like aviation units. This is the 8th Air Force Historical Society, and they have slightly different names. And you really gotta kind of learn that stuff and learn who is in charge of each of those organizations. Because for treatment purposes, I'm going to be talking about this stuff later on. So let's quickly review the different sized units of an infantry unit. A company is about, in World War II, 180 or so soldiers. They are commanded by a command team, which is a captain and a first sergeant. The first sergeant is the senior enlisted, and then the captain is the senior officer. So that's a company. That company commander has legal responsibilities, and that's why he's called a commander, and that's the captain of the company. A company is made up of several platoons, which are smaller, 3 or 4 depending on the organization. I believe for Army Ground Forces infantry in World War II, it was 3 platoons. Am I right on that? For those of you, it's 3 platoon. And a platoon is like about 40 guys, and they're guys in World War II. It's 40, it's a platoon leader. Notice they don't call him a platoon commander. There's legal reasons for this. Platoon leader, which is a lieutenant, a second lieutenant, or a first lieutenant. And then the senior enlisted soldier that is part of that command team of a platoon is called a platoon sergeant. So then that's 40 people. And then smaller than a platoon is squads. Squads in World War II, I believe, were 12 people in the Army. Nowadays it's like 9, I think, in the Army. Marines, I think, are 13, but it varies a little bit. So a squad is led, there's no officers in a squad. It's all enlisted soldier. It's a squad leader, is a staff sergeant usually. And then a squad can be broken down in 2 different teams. In Vietnam, they would call them fire teams. The nomenclature changes a little bit. But 2 teams can be broken down, like a corporal and like a sergeant, can lead those basically. So those are the smallest teams. Now so you got squads, which get together and become a platoon. You got platoons, which get together and become a company. Now let's go bigger. Bigger than a company is an organization called a battalion. Battalion is about 800 or so people in World War II in an infantry battalion. That's commanded by a lieutenant colonel, which is what I was, as the officer, and as the senior enlisted, it's a sergeant major, a command sergeant major of a battalion. The battalion's about 800. It's usually 4 companies in World War II get together, and you got a battalion. Higher than a battalion in World War II was the organization that's called a regiment. A regiment is commanded usually by a colonel, a full bird colonel, as they say, and a regimental command sergeant major would be the command team of that. We don't use that nomenclature now. It's changed in the current military. Instead of the regiment level above battalion, we have a brigade. That's a very good old unit that goes back to like way earlier than Civil War times and stuff. But nowadays we don't really serve under a regiment. It'll be a brigade. And when you get about 4 or so brigades together, or 3 or so regiments, 3 or 4 regiments together, they become a division. And a division is large. It's about 15,000 people in World War II. And that's commanded by a 2-star general, which is called a major general, and a command sergeant, a divisional command sergeant major would be the senior enlisted. And these guys are always command teams. And then bigger than a division is a corps. Multiple divisions getting together. It's a corps. You've got a corps commander, a corps, command sergeant major. And then higher than a corps, there's an organization called an army, which is usually a 4-star general. We don't wield units that size these days, but they sure did in World War II. In fact, they wielded even larger units than an army, called an army group. Now you're getting 4-star generals, and then there's a few people that got to be the 5-star generals and stuff, but they're way high up there for an army group. I bring all of this stuff up. It's important to review because, once again, every single level I've mentioned, they're all humans, and every single one of those people is subject to mental health issues, including PTSD and anxiety problems upon exposure to things. Okay, so I think we're done with the review portion. Let's start getting into the meat of this talk. Anyone have any questions on this sort of thing, or military organizations? I just went through the infantry stuff. Maybe I should briefly mention how the Air Force fits into this. They don't have like a company. They got things like flights and squadrons and groups. Those things would correspond to, say, a battalion, a company, a platoon. So just realize that when you're talking about different units, they're going to have different nomenclature, but the ideas are exactly the same. It's a chain of command. This is important because later on, when I talk about how military mental health works, they interact at various levels of this chain of command. And what I'm going to talk about is only going to make sense if you already know what all these different levels of the military are. Okay? Ready to move on? I think I bored you. Sorry. So let's start out really basic. What is anxiety? I mean, anxiety is the problem here. There's a lot of words for that. Fear, panic, worry, obsessions. All of these things are different manifestations of anxiety. Anxiety is, thought to be kind of a negative thing. in being alive as a human. But there's a reason we have anxiety. It's not a bad thing. It's actually a good thing in the right circumstances. The purpose of anxiety is that it helps you as an individual human adapt to a special situation that's occurring. It helps you, basically. So, for instance, if you are in a life and death situation and you don't have any anxiety, well, you're more likely to be killed or eaten by a tiger or whatever is the danger that's occurring to you. When you have anxiety, it gives you an edge. It gives you an advantage. You get to, your heart beats faster. You are numb to pain and stuff like this. You're stronger. You can run faster. You can concentrate better. You get an advantage when you have anxiety in you. It helps you survive, basically. It adapts you to a life and death situation. But there's plenty of other situations that are not life and death, and you can still have anxiety about that, and it will still improve your performance. So let's say you're in high school and you got to take a big test that's going to determine which college you go to or something like that. If you're not nervous before taking that test, you're not going to do as well. If you're nervous, once again, your reaction time's quicker, you're more focused, you have an advantage. So I would like to put out the idea that anxiety is a good thing that helps us all survive. This is why we as humans evolved over 100,000 plus years to be who we are, because we need to survive this. And the fact that we're here now says that, yes, our ancestors survived, and they had anxiety, and it helped them do that. Now, there is some problems when you have anxiety 24 hours a day around the clock, and that can have some side effects. It can help you get through the immediate situation, but later on in your life, when you're subjected to constant anxiety for like 24 hours a day, for a year, more at a time, I think you can see where I'm going with this. This sort of thing can wreak some havoc on your body, and there can be some side effects and stuff like this, and we're going to talk about some of that later on. So the purpose of anxiety is what I've basically talked about. It helps you survive. Signs and symptoms, I've mentioned them already. Heart racing, breathing hard, you're sweating, you're trembling, stuff like this. Having a panic attack, feeling like you can't breathe. That's physical type symptoms. Mental symptoms are you're feeling like you're going to die. You're feeling like you're going to run amok in panic. You're worrying. These are all mental symptoms of and signs of anxiety. The anatomy of anxiety is this: you have perception abilities in your. You got eyes, you got ears, you can feel things. You can perceive something that is a threat. Now, some things are perceived automatically, almost genetically, as threats, like a snake. Like a snake on the ground, your body's like, whoa! You can just perceive that so fast, it's almost unconscious. Spiders, too. There are certain things that just set you off. There are also certain things that you may not know are anxiety-provoking, but you can learn that they are anxiety-provoking, and that can sometimes be a bad thing. Like if you learn to be anxious around stuff that's not really a threat, you can see where this would be a problem. You would be experiencing anxiety symptoms when you shouldn't be. This happens all the time with people that have PTSD. So we'll talk a little bit more about this. So it's the anatomy of this. You perceive stuff. It's sort of quickly processed. You will lay down anxiety-provoking things in your memory, and your memory is stored. So that's the brain part of this. Now, when you feel anxiety, it goes down into your body, because it's not just in your head. You could feel anxiousness in your body. And that goes through the part of the nervous system that's called the sympathetic nervous system. There's another type of the nervous system that's called the parasympathetic nervous system, which you might guess, because of its name, it opposes the sympathetic nervous system. Sympathetic nervous system is all about the so-called fight or flight. You're going to do one of the two things. You're going to fight or you're going to run away, but you need to be strong for that and fast, and that's what the sympathetic nervous system relays from the brain to your body to make you stronger. The parasympathetic nervous system is the thing that helps you rest and digest. You're going to be relaxed. It also has to do with some negative emotions like shame and guilt. That's all governed by the parasympathetic nervous system. But the sympathetic nervous system is the thing we want to talk about. The sympathetic nervous system is the part of your brain and your spinal cord and your body that's called the autonomic nervous system. It means automatic. Let's just say it means automatic. You don't have to consciously think about it. It's just going to go. It's going to happen. And it's based on those perceptions that you've had in your head and the memories and stuff like this. And now your sympathetic nervous system is activated and you're feeling it all throughout your body. So that's a quick run through of the anatomy of what is anxiety and what happens in anxiety. This is all, of course, on an individual basis. It happens in each person as an individual. Then there are bigger levels than that, like a society, a group, and we'll talk a little bit more how group stuff interacts with the individual later in a bit here. So, all right, we've talked about finally anxiety, and now we're getting into, all right, this broad category that I'm calling combat stress. You see I got 3 things listed up here, a thing called a coaster, a thing called an ASD, and a thing called a PTSD. This is a sequence of things that occur in a person. You don't just get PTSD, and I'll talk a little bit more about that when we get there, but I think you already have ideas about that, so I won't explain it yet. You don't just get PTSD. You've got to go through several stages before you get PTSD. So, if you've been exposed to some kind of a traumatic, scary event, and you've had a lot of fear or horror about that thing, or you've been worked like a dang dog in the military, and you've had this high operational tempo, and you're working and working and working, and the grind is starting to catch up with you. You can have that first thing that's listed up there, COSR. It's not an official diagnosis. You're not going to find this in a psychiatry manual like in the civilian world. COSR stands for Combat Operational Stress Reaction. It's a mouthful. What it means is when you're exposed to these bad things of combat, or you've been having this operational tempo that you're just exhausted and you almost can't do your job anymore. You start to have in your body these stress reactions to those kind of events that are occurring to you. So in the military, we recognize that these are early signs which, if left untreated, can turn into things like ASD or PTSD later on. So the next slide is going to be about how the military intervenes here and tries to prevent this stuff from happening. It is that we recognize there is a thing called combat operational stress reactions. If we recognize this stuff early, we can treat it really quickly and simply and early, and that will prevent many people from advancing into these other worse things than a COSR. So a COSR is a military-specific term because of our special jobs and the special lifestyles we lead and the special stresses that we are subjected to when we are in a battlefield area, in a danger zone. So a COSR. This next thing I have here is an official diagnosis that any civilian would have heard of and been trained in. You know, I don't know if you guys know, there's this official manual that lists all the psychiatric disorders, and you can read this yourself. It's not secret information. It's called the DSM, the Diagnostic and Statistical Manual. They've been putting these out since 1952, and what it is they want to get all these terms that people throw out, you know, all these psychiatric and quasi-medical terms, and define them specifically, so everybody has a book and they're all playing from the same page. Because a lot of times in mental health stuff through history, since the 1800s and stuff, people were using terms in America that were not the same thing in Germany, although they were using the same term. So these diagnostic statistical manuals, which are public and you can read them, they show you all the different kinds of accepted disorders that there are for mental health purposes. And what are the criteria for those, what symptoms do they have, and how long of a time course do you need to have it? So you can read all of this stuff. So the ASD is, if you've got a COSR, a combat operational stress reaction, and it hasn't really been treated so well, and it's starting to get worse, you can have this ASD, this acute stress disorder. The last thing, as you read, is PTSD, post-traumatic stress disorder. These things all happen after some kind of trauma. It's not like it happens before a trauma. It happens after you've been exposed. So what are the criteria then for acute stress disorder and PTSD? What are the criteria? You get exposed to some kind of trauma and a traumatic event. I don't mean like breaking up with your girlfriend. I mean specific trauma, a life-threatening thing, a body-rendering possibility or something like that. That's a trauma in a medical sense of the word. So you exposed to a trauma and you have that fear reaction. Then you have those sorts of symptoms that I've already mentioned about the tremors and the heart beating fast. You can have some or all of those, that long list of about 14 things that constitute anxiety-type symptoms. But you need just some of that stuff. So you've had the exposure, you've had those anxiety-type reaction symptoms, and then you start to have what are called re-experiencing symptoms, where, okay, you're no longer in the traumatic situation, it's sometime later. It's a few days later, it's a week later. You're just sort of suddenly thinking about that bad thing that you have. You're almost sort of like you're back there, back to that trauma I experienced 2 weeks ago or something like that. You're there again, you're reliving it in your head. Then you have all those symptoms again. Now what you've got is a re-experiencing of the event that isn't there anymore. It's not there in real life, but it's there in your head. That re-experiencing could be with intrusive thoughts, daydreams, like I just said, or nightmares at night when you're asleep and you're like dreaming of that bad trauma that you went through a few weeks before. So there's several components there to the stress disorder, acute stress disorder. It's the exposure, it is those anxiety symptoms, it's the re-experiencing of those anxiety symptoms when you shouldn't be having those because the trauma is currently happening. And then the last major piece is avoidance. You try to avoid things that remind you of the bad event that you went through. You try to put that out of your mind. Those factors right there are what constitute this ASD, acute stress disorder, and PTSD. So what's the difference between these two things? It's a time frame. ASD is acute, that goes up to 1 month after the event that occurred to you. If you're having these symptoms and it's gone beyond that 1 month, now you're into PTSD category. Once again, if we intervene as professional doctors or therapists, early on, it's much easier to sort of nip the stuff in the bud and get rid of it and make sure it doesn't progress. But once it progresses, then it starts to have the potentiality for sticking around longer. So I want to make a couple of points about PTSD. We've all heard of it. It's really a hot topic that we've been hearing for decades now. It didn't exist as a proper diagnosis in that DSM that we've been talking about until 1980. Certainly PTSD and these other things existed before 1980. They just weren't called that. They weren't called PTSD. They were called other things. Most people are aware of stuff in World War I, called shell shock. Before that, there was a long history of other phenomena that would have been PTSD if you kind of read what they're talking about. For instance, in the U.S. Civil War, there were phenomena noticed that were sometimes called nostalgia. People that like are worried and they keep thinking of home and they want to get off the battlefield. They call that nostalgia. Well, I don't know. That could be like PTSD or something like that. There's another phenomenon around the time of the U.S. Civil War called Da Costa syndrome. It's like where your heart's beating fast and your blood pressure is going up and you're sweating and tremulous and trembling. Well, they would call it Da Costa syndrome. But wait a minute, that's anxiety. We call that anxiety now. So if you can read between the lines when you read this old stuff, they're just having different names for it. So that was the U.S. Civil War. Let's go back to World War I. So yes, shell shock. So 1914 to 1918, that's World War I. So in 1914, this is the first time ever that a major war was fought with high explosives. High explosives is a new thing. Before the World War I, they didn't have high explosives, they had explosives, gunpowder and stuff, but new advances in technology and chemistry caused high explosives to suddenly be available. And people didn't know what that did to humans. What if you're near blasts and stuff like this? So the idea of shell shock from many people exposed to these artillery blasts very close to them, and sometimes getting injured, but sometimes not getting injured. These blast waves hit you, and so people thought, oh my God, these physical blast waves coming through you, that must be the thing that is causing this stuff that we now call PTSD to occur. Well, within the first 6 months of World War I, so by 1915, they pretty much knew now that's not the case. It's not really a shell that has a shock wave that's doing something physical to you. It's actually a psychological thing. So they figured that out pretty quick, but they still were using the terminology, which is a slang term, by the way, shell shock. It was so popular, it caught on, and doctors did actually use that, especially in the British Army. They were saying, okay, shell shock W for wound, shell shock S for sickness. So people would be officially diagnosed with this, but the main higher up doctors knew, now this is a psychological phenomenon. So it took a while for that terminology, shell shock, to sort of drop away. And really what they started calling it in World War I is war neurosis. Neurosis. These are old, we still use them, psychological terms. But remember, World War I, psychology is not very old. Psychiatry is not a very old profession. So they're very much using those earlier terms like Sigmund Freud, and those guys were around at this time. And they were still operating from that area. So war neurosis is what they ended up calling a lot of this stuff that initially was called shell shock. But of course, regular people that aren't military professionals or medical professionals, they still call it shell shock, but that's okay. It's like a slang term. So war neurosis is what they called it in World War I. Now, World War II happens not long later, 20 years later, and here's the funny thing. People called World War I the war to end all wars, and they thought that was it. We're not going to have anything more like this. Well, guess what? Yeah, 20 years later, they have an even worse war. So they forgot how to treat all of this combat stress disorders that they learned in World War I. They forgot about that. And so World War II started, and they had to relearn all of the things that took them, 3 or 4 years in World War I to learn. So we forgot how to treat combat stress stuff and had to relearn. So in World War II, they came up with a diagnosis that was for PTSD, but the words had to be chosen carefully to satisfy all components. By that I mean the patients themselves, the soldiers, the service members, the patients, the commands, the units, the army, that have that soldier with that disorder, and the general public. So they had to come up with a new term in World War II to call what later became PTSD. What did they call it in World War II? Exhaustion. So you would be on a battlefield, and these exhaustion soldiers, patients, were a lot. So like, of all the casualties in a given encounter in a battle, often half of them were these mental health things that were referred to as exhaustion in World War II. Other people started to use terms like fatigue, battle fatigue, combat fatigue. But for the most part, exhaustion was the official thing that would be written on the diagnostic tag when a soldier came through, you know, the hospitals, the casualty clearing stations, the battalion aid stations, and all that kind of stuff. They would be called exhaustion. So, then, after World War II, Korea followed shortly after, and we still largely remembered these things because it was largely the same personnel. So they got fairly good treatment in the Korean War for all these kind of things. Then, weirdly enough, at the beginning of the Vietnam War, this stuff was still being applied, the treatment for these things, and it was doing pretty good for a while. But then the Tet Offensive happened in 1967. 67? Yeah, I think so. 68? 68. And then all sorts of things that people don't talk about a lot, like the enemy in the Vietnam War had a huge drug operation to supply U.S. troops with marijuana and heroin. And this was a military operation by the enemy. People don't talk about this very much. So all these drug problems started to accumulate in Vietnam, 69, 70, 71. It got very bad. When I was at Walter Reed, some of my teachers, my professors, were these guys from the Vietnam War who treated all these soldiers coming in with heroin addictions and like marijuana and just using this stuff constantly. This stuff was provided, you know, on the bases, you know, by the enemies of, you know, so North Vietnam and the Viet Cong basically were supplying this stuff. And it was, so anyway, so people don't talk about that a lot, but that just caused a lot of morale problems, and PTSD was kind of then got a lot worse, and it was kind of not recognized till later on. So 1980s, when finally, you know, whatever, 7 years after the Vietnam War, for the US anyway, 5 years, that was when PTSD was officially named and recognized. And so that's how we got there. So, we've got 10 minutes left. So how does the military respond to these combat stress things that I've been talking about earlier? The COSR, the acute stress disorder, the PTSD, the post-traumatic stress disorder. It responds with this thing, COSC, C-O-S-C, combat, operational stress control. So, how do you treat a COSR? What is it that you do to, if in your unit, your sergeants and whatever have noticed, hey, this Smitty is no longer a high-functioning private like he used to be, getting the job done. Now all of a sudden, he's off kind of like, you know, like staring into the distance. He's like, you know, Smitty's, oh, well, he's not getting his work done. He can't concentrate anymore. He's sort of not functional. He's not sleeping well. There's a change in this soldier. When they recognize this, the military, very low-level leaders were taught, hey, this guy might have this combat operational stress reaction. Get him over to the combat operational stress control people, and then they can treat those symptoms very quickly and restore him to his abilities to perform. So this is what they would do. They would take the soldier that's not functioning right anymore, pull him off the line for a couple days. The treatment areas were very close to the front line. They were like, in fact, they were within the divisions, but very close to the front line. So battalion aid station would say, hey, this guy that's just come in, you know, the squad leader would bring the soldier into the battalion aid station, which is the level at which the first doctor shows up on the battlefield, by the way. They don't have doctors at the company level, but they got them at a battalion level, and they're at the battalion aid station. So the squad leader brings the soldier into the battalion aid station. The medical doctor that's at the battalion aid station recognizes this as a combat operational stress reaction. We get him over to the combat operational stress control treatment people. Now in World War II, these treatment people were within the division. In fact, it was the guy that was called division psychiatrist, which I did in modern times, but in World War II, the division psychiatrist had no personnel. He just sort of grabbed medics here and there that were sort of good with mental health, dealing with people in a mental health way, and were sort of had some aptitude in it. And he would like put together a couple of tents, and they would call that the combat stress control area, whatever. So you bring the soldier with a combat stress reaction to the combat stress control area. It's a couple of tents within the division. You keep him there for a couple of days. You let him catch up on all that sleep that he hasn't had for the last 3 weeks. You give him some meals. You let him shave. You let him have a shower if there's shower facilities. In fact, the slang term that the soldiers would call this combat stress control treatment in World War II was the 3 S's. And I'm going to swear here. Sorry. Just be prepared. A shower, a shave, and a shit. So they would bring you back for a day or two and let you sort of restore yourself, and you'd go right back on the line. So instead of having a soldier who's like sort of malfunctioning and just keep him on the line till he gets worse and worse and no longer functions at all, you recognize early that the soldier's sort of not functioning right. You get him to the combat stress control. It restores him to his full self, and now you got a fully functioning soldier. Okay, you missed him for 3 days, but I mean that was the trade-off. And so you can see that the company commanders, the platoon leaders, the battalion commanders really bought into this idea, and this was thought to be a very good thing. And once again, they called this exhaustion. So there's no stigma about it. It's like, oh, you're just exhausted. Oh yeah, everyone, we got it. We all get exhausted. Okay. So now it's no longer looking like some kind of abnormal thing. It's looking like a normal thing. So all of these techniques help these soldiers, these service members, get restored rather rapidly, 2, 3, 4 days, then they're back at the front. Now, does that work for everybody? No, not everybody. But these people treated in these COSC centers, these combat stress control centers, something like 90% of them, 95% of them, it worked. And they went back on the line and then were able to function. Now, there is another phenomenon I should tell you about, which it is, let's see, I've got 5 minutes left. There's a cumulative effect, all these continuing trauma exposures. So you might get restored the first time. You might get restored the second and the third time that something's happened to you. But they found that after you've been in a combat situation for so long, everybody eventually breaks and you gotta go back home. They would call this the old sergeant syndrome. Just as a sort of a slang term, the doctors. So you'd have these sergeants that are doing fine until, on average, it turned out to be the 88th day or so on the front line. That's what the statistics sort of add up to when you look through it. The 88th day, you're broke and you can't function anymore on the front line, and you just can't do it anymore. So what do they do with those guys? They didn't send them back to the U.S. and put them in a hospital. They sent them to somewhere else that was out of the battle zone, because there's so many of those combat support, service support areas that are needed. Well, that's what they ended up doing. They went from a combat unit to like a combat service support unit, and they were still doing their duty and getting things done and being used by the military. Now, there were a few people, sure, that were so significantly traumatized that then they had to go back to the U.S. and they had to get discharged out of the Army. And I've certainly dealt with people like that, but that's not even close to the majority. That's a small minority of people. I'm going to just throw some estimates out there. Maybe 5%, something like that, can no longer function, and they have to be removed from the military. But for the most part, these combat stress control techniques work. So the last thing I have here is military health or mental health personnel in the battle space. Where are they exactly, and who are they? So at the brigade level, or well, in World War II it would have been a regiment, you've got 2 mental health providers. You had a psychologist and a social worker who was trained to do therapies and stuff. So the first place in a big unit like a division, you would have these people attached to the division as staff in the brigades, 2 of them. The first place in the division where you would have a psychiatrist is at the division level. So the whole 15,000 people, are gonna eventually get up to a psychiatrist, there's one only. So in a given division then, if it has like 4 brigades, that would be 8 plus, so 9 personnel within the division that are actually mental health professionals and can treat these people. So that's not enough. So what they also have, since about the Gulf War I, 1991 or so, are these new units, well, new for the 1990s, and they still have them, called Combat Stress Control, COSCs. They're medical detachments, like a company-sized unit, a little bit smaller than that, medical detachment, that sole purpose is to provide outpatient mental health care. So you've got social workers, you've got maybe a psychiatrist or 2, psychologists in there, along with these mental health personnel, enlisted soldiers. They're like medics, but they're for mental health stuff. They're called mental health technicians, is what they're called in the Army. So mental health medics, along with these treating professionals in these COSC units, these medical companies. Now they're an area support company. That means any division or any stray units that are in that area, if they need some mental health treatment, they go to the COSC. They go to the COSC. So I've done that sort of thing. They did not have that in World War II. It was all done in an ad hoc fashion by the division psychiatrists, just making up these little COSC things. So like I said, it wasn't until about 1990 that the military said, we should probably just have a unit to do this. And so it took them a long time. So that's the current situation for mental health personnel in the battle space. The mental health people have to interact with commands all the time for that particular soldier. And one of the other big assets that I have to mention, and we're in our last minute, one of the other big assets that helps out with mental health in the battle space is chaplains. We work very closely with the chaplains, and they always did back in the day. I mean, okay, what's the difference between the mind and the soul? There's a lot of crossover here. So the chaplains for sure help us out a lot with this. So we as medical providers, mental health providers, will be talking to the chaplains, and there's a lot more chaplains around too. I mean, I've already told you that the first actually licensed medical provider you get in an infantry division is at the battalion level. But you get more chaplains too, and they can help out with this. So it's more like the help is there, and you got to find it and reach out to it. What we call that is consulting. That's an important principle of mental health in the military. You consult with the command. You consult with the medical doctors that are not mental health. You consult with the chaplains. So there's talking back and forth constantly. It's not like in movies where they just go off and do stuff by themselves. You're constantly talking to different parts of the unit in addition to helping out the individual soldiers. So this has been like a very, very broad overview, and I finished just right on time. Any one of these areas that I have spent 5-10 minutes on could be expanded into an hour-long talk at least. I didn't even really talk about the proper history of this stuff being developed during World War I, because the combat stress control stuff that we do today is like 95% the same as what they did 100 years ago. It's not like we're doing some magical, crazy, or off-the-wall thing. These are tried and true things that were discovered when massive amounts of soldiers and service members were being lost to their jobs in a combat setting. So, the big military, the non-mental health folks are really, in my experience, on board with doing this stuff because it helps preserve the fighting force, basically. That's what this is for, so we can get the job done that the military needs to do. So I think I'll end there. We have a lot of time for questions. Roughly, it's a quick estimate off the top of my head.
That were sent back home and discharged. What kind of discharge did they get?
Well, and it's interesting you mentioned there's a history to this. So remember I was saying in World War I, the British Army had a diagnosis for a few years called shell shock W and shell shock S. Shell shock W means it was a wound, means like the explosion just happened and it was witnessed and was written down. And and we're gonna call that shell shock W. Those guys would get compensated. They would get, it's workman's comp. Oh, you can't do that job anymore, and maybe you can't do many other jobs all that well, so we're gonna compensate you for the rest of your life. Shell shock W got compensated. Shell shock S did not get compensated. Shell shock sickness. It was thought that maybe this is a defect in their character. But look, tens of thousands of guys are getting blown up and they're like coming into the aid stations and they're trying to get, is this accurate? And who's making a call at what's a shell shock wound, shell shock sick? So back then, some of them got compensation and some did not. As time has gone by, they get compensation, which is, it should be tied to the severity of the PTSD. So if you have severe PTSD, which is not responding to treatment stuff, you're going to get a higher compensation than somebody with mild PTSD. In fact, okay, now here's another kind of disturbing factor. Congress gets involved sometimes and passes laws, and they passed a law, I forget what year it was, 2005 or 6 or whatever, showing that they want to support personnel, which is very nice. But they said something like, anybody with a diagnosis of PTSD automatically gets at minimum 50% of their military, whatever, 50% or higher, has a minimum of 50%. But wait a minute, what if the soldier has mild PTSD that's responding to treatment? Nope, you gotta give him 50%. It's like, the guy can still work some other jobs somewhere, but nope, Congress has said it's gonna be, so unfortunately now, what that means is PTSD can become a desirable diagnosis for compensation purposes. So sometimes there are people that want to take advantage of that, and most of the time not. I'm taking a risk telling you this in public because sometimes people don't want to hear this and they want but this sometimes happens. It's a small percent, but sometimes people do take advantage of this. And Congress has basically passed a law. I mean, I don't know what the current status is with that law, if it's changed, but any medical, any workman's comp in the civilian world, you should get compensated, but it corresponds to the medical severity of that thing. If it's just you're a little bit disabled, then you get a little bit of money, and then you can, if you're completely disabled, then you get more money. It should be tied. Well, of course I would say that, I'm a medical doctor. The disability should be tied to the severity of the illness. But sometimes other factors intervene, and then it complicates things. So I might get some hate mail now. This has happened to me before. Yes, Colonel Pat.
Is it fair to say that different people react to the same thing at different levels?
Yes.
This is maybe a question you can't answer. We can talk about it later. But, in World War II, the 106th Division.
Battle of Bulge.
Battle of Bulge.
Yeah, Elston, or one of those heights. Yeah.
The war was winding down, and a guy by the name of General Two-Star Major General Jones was a Pentagon desk writer. He had written the way up to Two-Star General to write a desk. But he is a good-looking guy. We need to have him in the postal area. So they just sent him as the commander of the 106th Division.
Right.
When the Battle of Bulge broke out, the 106th was the center
Right.
of the German attack.
Just by bad luck.
And he went, and he actually became dysfunctional.
Yeah.
Now, how do you, there's a myriad of questions. Do they do psychological tests to assign?
For high up generals.
Well, for any.
Yeah.
In fact, as you were talking, did Callahan, when he did the My Lai massacre,
Sure.
did he?
Oh, I'm sure he got many.
Yeah.
Yeah. So for the camera, Colonel Patton is talking about the 106th Division, Infantry Division in the Battle of the Bulge, which famously resulted in the largest surrender in American history, because it was basically a brand new unit, actually, and it was a new commander. I mean, they were untested. To respond to that, I would say that a lot, so the breaking down and the frequency of this combat stress reaction stuff is directly related to things like the morale in the unit. Are they an experienced unit? Are there some old hats in there who know what they're doing and calm down the young ones? What we got here is a brand new division. Yeah, they're the ones that are going to break more than a more tested division and stuff like this. This is why they had cadres from other divisions populate the new division, so you'd have some old hands in there that would sort of, hey everybody, this is a combat stress reaction, this is normal. Well, they probably didn't use that language, but this is normal, and get you back to the battalion aid station, and you'll come back in 3 days or whatever. So that commander himself, the factors that go on in the unit that directly relate to how high the combat stress percentage of soldiers experiencing that are, how is that leadership in that unit? What is the morale? Well, there's all these kind of nebulous, but very important. What's the esprit de corps in this unit? Those units that are more elite, they have less of this stuff, because those are those hard to quantify psychological factors, but they're real and they're there. They had less of, they still had this stuff. I mean, whatever, 82nd Airborne, 101st Airborne, Band of Brothers on the TV show. They still had their combat stress, but compared to like a new division, less, because.
Which is the reason that realistic training is so important.
Realistic
To try to bring out those stresses before.
Realistic training is such a thing. It's a controversy, but my personal opinion is realistic training before you get into the battle helps you anticipate things such that PTSD and other things are less likely than, for instance, a civilian population. Civilians can get PTSD, we haven't even talked about this. Car accident, getting mugged or raped or something like this, bad stuff. Yes, PTSD, civilians get this. I have an idea in my mind that I think, because civilians don't have training or anticipation for that stuff, it just happens. I think the military at least get training and realistic training, so there is some expectation that they can have, that they might be exposed to this. I have a question that I think that maybe military people might get less PTSD compared to the civilian population, because at least they get some training and at least they get, I'm not positive on that. I got to look at literature. I'm sure people have asked that same question, but my guess is that there might be less. At least it's helping people anticipate that these are going to be a problem and get treated quicker. Whereas in the civilian world, you're just on your own. I mean, when you look at the active duty regular Army, which I've had experience, and then the Reserve, the Army Reserve, the National Guard, those are citizen soldiers. They're citizens first. They don't have their eyes on each other very much, one weekend a month or something like that. The suicide rate is higher in those reserve units and National Guard units than in the active Army, because at least there's people around all the time and has their eyes on you every single day, basically. So that might be related to this. I mean, the civilian citizen soldiers, God bless them, I was one for 10 years, but they're half civilians, kind of. And I don't mean that as an insult or anything, but they kind of are. They don't have quite the same culture. And I think a lot of this stuff kind of gets some of the safety pieces of being in the
I think
regular
there's actually
military.
a corps commander in the Battle of Bulge that became dysfunctional.
Possibly. You know, here's a good example of a heroic guy, a leader. Norm Kota. Norman Cota, 29th Infantry Division.
Assistant division.
Yeah, D-Day going in with the 29th Division, you know, helping out these guys and whatever, leading some squads. This guy, what DSC did he get? Distinguished Service Cross? Almost a Medal of Honor. I mean, so this guy was heroic. He was the assistant division commander and on D-Day. Wow, what an accomplishment. Well, he's so good, let's make him a division commander. He gets to be division commander of the 28th Division, the bloody bucket out of Pennsylvania. Okay, now he's at the Hurtgen Forest, and he does very badly in the Hurtgen Forest. So okay, is there some mental health component of that? Hard to say. Interesting guy. But he had heroic at one time, and then he had like kind of a very bad experience. If you guys know anything about the Hurtgen Forest, those battles, it was very, very bad. Huge amounts of this kind of stuff, combat stress reaction, ASD, PTSD, and all that kind of stuff. Exhaustion is what they called it back then. Huge.
Rob,
Low morale. Oh, yeah,
One
I
more.
guess I'll go with you. Yeah.
Last question.
Well, he's got a question.
Well, I think-
Second to last question.
Two movies of my youth were war movies that were anti-war movies, Catch-22 and MASH.
I like those movies.
And so, is there any modern equivalent to a Section 8 and a Catch-22?
Yeah. I for the longest time, am looking at, Section 8. So you guys know Klinger on MASH, right? He's wearing dresses. I'm going to get that Section 8. So you get separated. There's administrative separations from the military. He's not getting like benefits for that. You know, he's not going to get compensated for this Section 8 Klinger going home. But he'll get him out of the danger zone and stuff like this. And obviously on the show, Colonel Potter and whoever else recognizes that, hey, he's just, as the British would call, working his ticket. He's working his ticket. He's just kind of manipulating the system. So they responded appropriately. That no, Klinger will just, okay, no, you keep doing your thing and whatever. So yeah, there is an equivalent to that. It's not called Section 8 anymore. There's all sorts of administrative discharges. They are honorable ones, there's other than honorable ones, So there's different, yes, and that is sometimes employed to get people that are acting up and doing disruptive things in the military.
Did those people make it to you, or they did?
Yeah, they have to. In fact, the Surgeon General's office said, okay, the command suspects this guy of some kind of malingering or something. But before you can administratively discharge this soldier, you are required to get him seen by a psychiatrist, a psychologist, and they have to sign off on this and make sure that it isn't PTSD or something related to that. So yeah, the system has checks in place to make sure that bad things, like nefarious things, because sometimes leaders, they don't like a soldier, and maybe they're going to use their advantage, and I have unfortunately seen this. There are sometimes leaders that will manipulate a system to get rid of people they don't like in an unfair way. So there's protections in place to make sure that kind of stuff doesn't happen. But sometimes it does. It's hard. I mean, we're talking about 100,000 plus people, and so many different things can happen. And the system has things in place to make sure that stuff doesn't happen sometimes.
Rob, here's the last one.
Yeah, okay, I'll talk to you.
Next to last.
Okay. Yes, sir. Engineer.
Well, obviously, we knew something about this in World War I, and then the civilian society forgot.
Well, the military society forgot it also
The military,
afterward.
yeah, but
Yeah.
basically, we're training most of our mental health professionals in the civilian society.
Mhm.
Is there enough recognition that PTSD occurs like it does, as you mentioned, rape victims, other people?
yeah.
Are we going to, at least in the civilian society, advance that cause of mental health so that we don't have to relearn this?
Yes.
If we ever get into a major war?
I think so. Yeah, you're talking about those that's happened several times. The period of we've learned something, then it gets forgotten, then it has to get relearned, and in fact, it's even at the early parts of relearning exaggerated, and then it's like, oh no, we go do the research and we find out what's happened before. So one thing the military has done to try to ensure some continuity across the generations of time is to get a lot of the people that were in the military replaced by civilians doing certain of those administrative jobs. So these civilians will stay in the same job for 20 or 30 years, whereas in the military, you stay in the same job for 2 or 3 years, and you're moved on, and you're moved on, and you're moved on, and that institutional knowledge gets lost. But that, I don't know when that was
As a
implemented.
long-time reservist, you have to, in designing force structure, what units are on active duty, what units are in the reserve, you have to have a feeling. Do we have enough people in the civilian society have these skills? We can come up and teach them to march and they can do their job. Like,
Yeah.
you know, civil defense units or civil affairs units don't need to be on active duty. You can learn to be a police chief in civilian life. You can learn to be a fire chief in civilian life.
Or an engineer.
Or an engineer.
Yeah, absolutely.
Bulldozers.
So you put those units in reserve. You don't put them on active.
I think so, and so I think there is a lot of institutional knowledge, and the COSC stuff isn't that difficult. So you can get a civilian psychologist who's never done any of this, but they're patriotic enough to join the reserve, and then they can get taught this stuff. It's a 5-day course at Fort Sam Houston, this COSC thing, so it's learnable, but there's components to it too. Like you've got to learn how to talk to regular Army units. You got to talk to a company commander, a battalion commander, and you don't just talk to them like, "Hey, how you doing, Joe?" You got to use some military protocols. So all of that. So hopefully they get that when they're in the reserve, but sometimes they don't. But I'll tell you.
But we got to have the skill in the civilian society, the basic.
Agreed, and I think we have that. I think my look at the generations, like I was in it for 20 years, Generation X, then Generation Y, or Millennials, and Generation Z. Mental health has become more and more accepted. It's no longer thought to be a dodge as much. Some people do. The stigma against mental health, like is it real, is it fake? There's less and less of that as time goes by. The problem, though, is Generation Z people, the young kids, they seem to be a lot more fragile psychologically. Like, for instance, they just go right to suicidal thought. Like, you know, Generation X, this is the last thing we thought about. I mean, it just never occurred. But there's something about the culture that it's a thing that people almost accept, or I'm not quite sure. But it's hard to say. I don't want to say anything disparaging. They accept mental health, but at the same time, they're more fragile. Yeah, there was more resiliency, it seems, to older generations, but there was all that stigma against mental health, so that was a bad thing. Uh-oh, Steve's giving me this. Means we're gonna form up. We're gonna have a convoy. Oh, cut it off.
After the first of the year, for sure.
After the first of the year, I'll come back and do more.
Dave, did you have a question?
Well, one, for everybody's benefit, what should we Google to find out more about the topic as it relates to World War II? And then in general, what would be some search
All right.
words?
First of all, you know about the Army Green Book series? That's the official history of World War II. It's the Green Books. That's operational stuff. There are a series of brown books, which are the medical department histories of World War II, the Army. There's 2 volumes of that called Neuropsychiatry, NP. Neuro, meaning neuron, nerve cell. Psychiatry, the mind. Neuropsychiatry, Volume 1 and Volume 2. But these are online. At the end of a Google search, you can read the entire book. It's online. It's about 600 pages. It's a dry textbook using old terminology. I don't know how much you're going to get out of it. But you can check them out. Okay, here. We like movies, don't we? Here's something to search for that's going to illustrate a lot of combat stress. It's on YouTube. Here's your search criteria on YouTube. Combat Psychiatry, Battalion Medical Officer.
Say it again.
Combat Psychiatry, Combat Medical Officer. It's a training film, very highly professionally done. It watches like a movie. It's like 38, 40 minutes long. It's a a very high quality, black and white, 1954 this came out, right at the end of the Korean War. And then of course they released it and the war was done. So they had a perfect training video, which was to train medical providers how to do mental health stuff and what to look out for. And then I'm not going to use words like COSER and all that and PTSD, but this is for the battalion aid station. I was telling you about battalion earlier. The guys manning it, there's 2 usually. These days it's a physician assistant, PA, and maybe a medical doctor, but back then it was medical doctors, MO, battalion medical officer. This is a Marine Corps film I'm telling you about to go watch. Marine Corps, it's infantry, just like the Army, but so it's very much the same, except the Marine Corps does not have any medical personnel. They take their medical personnel from the Navy. So they have Navy ranks, so they call them like commander, and they call them like corpsman, so you'll be seeing Marines, but then there's these corpsmen and stuff like this, and then these like lieutenant commanders and lieutenants, but they got a railroad track bar, like that's a lieutenant in the Navy. So anyway, so you might get a little confused about that. So watch that, that's a great film. There's a sequel to it called Combat Psychiatry Division Psychiatrist. I have that on YouTube, but it's on a secret link. Because it's not available. And then maybe I'll give that to Steve, and you can watch it. That's the sequel to this, so that's a 40-minute film that shows what happens battalion and lower. And then the second half is what happens at division, and it's the same thing. And Fess Parker and Leonard Nimoy are in it before they were famous. They played Marines. So,
It's Captain Newman, MD,
Captain Newman, MD, Gregory Peck.
Leo Roston. It's
Yeah.
a movie and a book. It's representative of what Rob's talking about.
It's pretty good. I like this training film a little bit better, but Captain Newman, MD, for sure. 1959, whatever year it is.
Thanks, Ron.
Yep, no problem. Thanks, guys.